Welcome to the Primary Care of Women. This is Katrina, and I just wanted to give you guys a brief welcome to the class. I'm sorry I have laryngitis this week, but I promise this lecture won't be very long. So I just wanted to touch on a few just things to consider as we transition from being RNs to being advanced practice nurses. And I think one of the trickiest adjustments that way is deductive versus inductive reasoning. So with deductive reasoning, you start by knowing something, so you already essentially have a hypothesis, and then you can make assumptions from there based on what you already know. So thinking about maybe your role as an RN, you know that this patient has a bladder infection, so that would make sense why you're calling in a prescription. That would make sense why she's saying she's having burning when she pees. You know all of these things based on that initial hypothesis or understanding that she has a bladder infection. You understand what a bladder infection is, and so you can make assumptions on what you need to do from there. Same thing if you're taking care of somebody who has tuberculosis. You're expecting that we might be having some respiratory issues, so you can anticipate those needs. That's deductive reasoning. And that would be essentially your role as an RN. Whereas switching to the advanced practice role, there's more inductive reasoning. So when women are coming in, they don't have a diagnosis yet oftentimes, and it's us needing to be able to come up with a diagnosis, and that working backwards is inductive reasoning. So somebody comes in and says, hey, I'm having burning when I'm peeing, and it kind of stings. Your role as an advanced practice nurse then is to figure out what does she have, and I think following the process for a SOAP note is essentially the process you're going to do. So before you even walk into a room, you know what her common complaint is, and you can start to form a list of differential diagnoses. So you don't have a hypothesis you're working off of, like with deductive reasoning where you already know what it is. You're needing to create that hypothesis, which starts with that differential diagnoses list. So maybe you know she's having stinging when she's peeing, so you've already come up, you're thinking, probably it's a bladder infection, but maybe for all I know she has a kidney infection, or maybe I wonder if she's having any pain with sex. I wonder if it has to do with that, or I know she had a baby last week. I wonder if there's something funky going on with her stitches or her wound healing there. So you start to come up with a list of differential diagnoses in your head right from the get-go, and then you walk into the room, and then that S part of the SOAP note, that subjective piece, you want to fully flesh out. So you're doing the old carts or whatever mnemonic you have for thinking about how long have you had this? How would you describe it? Is it, have you tried anything to make it help? What makes it better? What makes it worse? And you're going through all of those questions to get a good HPI, and then you're evaluating any related systems as well, that review of systems. So that's where the pain with sex might come in, or have you noticed any change in your vaginal discharge, that kind of thing. And then you would move from there to the objective piece of your SOAP note, right? And then you would collect any kind of physical findings that are related to that chief complaint. And then once you have all of that information, then you're making your full differential diagnoses list. And from that, you're picking whatever is most likely. And if it could be that you end up with 2 or 3, and you need to do labs to get a little bit more information before you can know for sure. Or it could be that one thing is far more likely, but until you get this test back, you won't know for sure. So then for that, the A part of your SOAP note, the assessment, when you're putting your diagnosis, you're either putting a straight diagnosis, or you're going to put, this, but rule out that. So that would basically mean that you would have 2 differentials ultimately that are on your list, where the rest of that will flesh out once you get lab results back or whatnot. So I think that's probably the trickiest transition, is really taking a step forward and saying this is what my diagnosis is going to be, that inductive reasoning piece, which I'm sure you will all adjust to really quickly. And I just wanted to give us a little bit of a framework for how we're thinking about primary care, which applies both to this course as well as your pharmacology course. You do not need to know how to treat every condition when you graduate. I think it can kind of feel overwhelming once you start to get into all of this. But I want you to know that when you graduate, you are completely surrounded by other providers to consult with as well as to refer to. And you will also have a host of reference books and online references that you can go to help work through it all as well. But here's what I want us to really dwell on. Common things happen commonly. If a woman who's 10 days postpartum comes into your clinic complaining of a painful lump in her breast, it is more than likely going to be mastitis, not breast cancer, right? So what we really need to do is when we think about different body systems, we should know what the most common things are to diagnose within that realm. So whether that's mastitis or say we're talking about respiratory issues, knowing asthma, knowing bronchitis and pneumonia. So those would be our horse. Whereas breast cancer in a woman a week postpartum is more likely to be a zebra, right? So we don't need to know all of the ins and outs of our zebras or our red flags. What we need to know thoroughly is our horses. So we know how to diagnose and treat the most common conditions for different body systems. That being said, we should know what our red flags would be for zebras so that we're not overlooking something that would be concerning to be a zebra. And then if it turns out we're heading in the direction of a zebra, that's where either you're doing a lot of extra research or you're consulting or you're referring. So our goal for this class is that you would feel comfortable around the most common conditions that would come in for primary care and for women's health. And ultimately that you feel confident in knowing where to find your answers too. I cannot tell you how often I'm still constantly using all my reference books, and that's just fine. Okay, and then I just wanted to close with thinking about transitioning to women's health and primary care. Oftentimes when we think about the hallmarks of midwifery, we're really dwelling on pregnancy and birth. And so much of this applies to women's health and to primary care. And I just want us to walk into this feeling that congruency of me caring for well women who aren't pregnant and aren't thinking about becoming pregnant soon. This very much fulfills who I am as a midwife and what kind of care I want to provide. So at first I was going through and bolding the ones that I thought particularly applied to primary care, but honestly they all apply to primary care. You really can't distinguish between them. But our recognition of menarche and menopause as being normal processes, I think that's huge for women as we come alongside them in their care, and that we're empowering them to be partners in their health care, that we're intentionally being promoters of health, and that we're providing robust education. That's what our women in pregnancy love about us, is that they just get so much extra education as they go through the journey of becoming parents. Let's do that for them with their health as well. I love annual exams for that reason, just a chance to say, hey, where are we at with your health? Where do you want to be with your health when you come in next year? And being able to provide all of that extra education and counseling around health promotion, I just think is beautiful. Care for vulnerable populations, that definitely is an issue in our country for pregnancy and birth, but for primary care as well, that we're there and ready to be present. The word midwife means with woman. And our national organization, the American College of Nurse Midwives, our motto is that we are with women for a lifetime. And that absolutely extends beyond the childbearing years. And it extends to be the parts of the childbearing years where we're not childbearing. So I just wanted to leave that with you as you enter your clinical sites. It's exciting to be with our pregnant women, and it's exciting to just be with women, period. And what a privilege it is for us to come alongside those women. So blessings as you start to enter into your clinical sites, and I look forward to starting to hear all of your stories. You are going to be such a blessing to so many women, and I am just grateful for those mothers that they get to have you. All right, have a great week.